Welcome, everyone. Thank you for joining us this evening on Modernizing Medicine's webinar around turning revenue killers into opportunities, where we'll go over the outlook for 2015 for gastroenterologists. Before we go there, just a little bit about Modernizing Medicine. Modernizing Medicine was founded by myself. I'm a board-certified dermatologist, trained at Yale, and was on faculty at Harvard. Was in private practice in Florida, missing the snow, and ran into a patient who was the founder of Blackboard. Blackboard is a company that Dan Kane grew from its beginning as a college sophomore to a $1.6 billion company and IPO. Modernizing Medicine is really focused in the subspecialties. Our success thus far, we've had some mentions from Forbes as one of America's most promising companies multiple times. We've been a Red Herring Award winner, which is a award given to high-tech companies. Previous recipients were Google and Facebook. We were the Southeast Regional finalist for the Small Business of the Year, and we're also one of the best places to work in healthcare as well. We recently won the 2014 Healthcare Leadership Award, a national award in the U.S. Chamber of Commerce. Our markets that we're in, we started in dermatology. We have almost 30% of that market. I've launched ophthalmology, orthopedics, and plastic surgery, and gastroenterology as well. I'm going to introduce Dr. Elliot Ellis and Dr. Julie Servoss, and they will kind of explain their role with the company. Elliot.
I'm Dr. Elliot Ellis. I went to medical school at the University of Pennsylvania, where I did my undergraduate studies as well. I did my residency at Yale and did my GI fellowship at Mount Sinai in New York City, where I was the chief GI fellow. I've been practicing gastroenterology over the past 5.5 years in South Florida, and over those years we went through 2 electronic medical records without success. We became extremely frustrated with the products that we used, and our practice actually went back to paper. About 1.5 years ago, I saw Michael Sherling's product, EMA Dermatology, and was totally wowed. Michael asked me to help build the gastroenterology platform, which we built over the past year or so. And over the past 6 months, we've been using it exclusively in our practice with amazing success.
Good evening, everyone. My name is Dr. Julie Servoss. I'm the medical director of EMA Gastroenterology, and my partner is Elliot Ellis, who just introduced himself. I trained at Harvard Medical School and did my internal medicine, GI, and hepatology fellowship at Massachusetts General Hospital. I, like Michael, do not miss the snow at all. I'm sorry for those of you who are calling in from New England, but we feel your pain. I also did my Master of Public Health at the Harvard School of Public Health, and when I saw EMA Gastroenterology about 7 months ago now, I, like Elias, was completely wowed, not just by the medical content, but also the workflow, and specifically my interest in clinical research, the fact that EMA Gastroenterology and all of the EMA products actually gather structured data will help us not only for research purposes and outcomes, but also some of the things we'll talk about tonight, such as PQRS. So welcome to our webinar.
So without further ado, let's go into the 2015 webinar revenue killers, not webinar killers, because that would be sad. And here they are. So ICD-10, an explosion of codes from 13,000 ICD-9 codes to 120,000 ICD-10 codes, coming to us, a clinic near you, October 1, 2015. Meaningful use stage 2, quite onerous compared to meaningful use stage 1. Definitely a potential revenue killer. Physician quality reporting system going from a 2% penalty for pay for reporting to a 4 to 6% penalty for pay for performance. The value-based modifier that is linked to PQRS, medical necessity, and telemedicine. But I promise we're not going to be just a negative. We're going to actually be positive and show you how, through using EMA, we have solutions for these issues. This is how a lot of us feel. We're sitting on the train tracks. We know that a train could hit us October 1, 2015. We know that by not doing PQRS this year, we could get penalized in 2017. Yet, a lot of us, we're business people, and we feel like maybe the grass isn't so green on the other side. Maybe it is more, we'd be better off by ignoring all of this compliance and just taking the penalty and just having a really efficient practice. And these people are believers in the zero-sum game. And if I do a good job, I will dispel the myth of the zero-sum game. So these people believe that saving money on ICD-10 implementation will just net you an extra 2 to 3 minutes filling out each super bill, and that avoiding the PQRS penalty by spending an extra 3 weeks putting in data really isn't for them. And worst of all, paying $100,000 up front for an EHR, that just slows you down, right? So we're all business people. We want to make sure there's an ROI for anything that we do, and that it avoids this trap of the zero-sum game. And these people believe that you're just going to pick your poison, whether that's increased time, penalties from lack of government compliance, or hiring more staff to keep up with the compliance. They believe that you're going to lose in one of them, and if you lose in one of them, it basically negates the benefits of doing a solution for EHR or PQRS or ICD-10. So the game is to turn a revenue killer into a revenue opportunity, to leverage automation to increase efficiencies, eliminate penalties, and reduce extra staff effort, and above all else, avoid the zero-sum game. And we are going to play right now. So let's do an example. This is one we all know. Let's say this physician, Dr. Smith, is a 60-year-old physician in solo practice who wants to practice another 5 to 10 years. He has been slow to adopt technology and is currently using paper medical records. He does not wish to participate in any government stimulus plans because he doesn't believe in the economic value of EHR, but he is concerned about ICD-10. How much does he stand to lose? Well, let's talk about it in terms of time, money, and staff. So if he doesn't invest in the time to train his practice, he could be potentially spending up to 2 minutes per super bill. Why is that? Well, ICD-10 has a lot of nuances to it. Instead of 5 digits, there's up to 7-digit code. So each code is like a phone number. Instead of 50 codes that might fit on a super bill, those top 50 diagnoses in gastroenterology could map up to hundreds of codes, which can't fit on a super bill. So you're kind of constantly searching for the right code. And if you don't have the right order of things, you may be spending time overturning denials. Let's look at the money of it. The American Medical Association did an estimate for small practices, and they say that there's going to be investment of between $50,000 and $100,000 to get people ICD-10 ready, whether that's consultants or books or crosswalks. It isn't easy. And for larger practices, if you're in a bigger GI group that spans multi-locations, that could be up to $200,000 to $800,000 of investment. And that's because if the codes aren't correct, you could get denials, and that could be an opportunity cost for your revenue. And finally, if you don't pay for it that way, you'll pay for it in staff, right? So getting consultants and billers to double check everything that you do, and in the end, you feel like it could be a zero-sum game. Enter Modernizing Medicine. So we have an ICD-10 solution that really automates everything. And this is the way a lot of people feel about this. Here's an ICD-10 code V97.33XD, which sucked into a jet engine subsequent encounter. There is no intuitiveness to these codes. Obviously, if you were sucked into a jet engine, there wouldn't be a subsequent encounter for that experience, yet they've thought of almost everything. And these things get really cumbersome. So a lot of competitors are going to say, you know, we've got an ICD-10 solution for you. We've got something called a crosswalk. Think of it as a pocket translator that takes the ICD-9 code and turns it into an ICD-10 code. Why don't we just take one that's really common, ulcerative colitis? 556.9 maps to K51.90, or so we think. But there's a lot of ulcerative colitis codes. And which one should we pick? Well, it depends on a bunch of things, right? It depends where the ulcerative colitis is, whether it's left-sided or not, and then what kind of manifestations there are, whether there's bleeding, whether there's an abscess or another complication. And this type of battle, you don't want to have to be doing every single time you make a diagnosis. Crosswalks won't help you with it because crosswalks assume there's a one-to-one relationship between an ICD-9 code and an ICD-10 code. We know that the ICD-9 code to ICD-10 code is a one-to-many relationship, and that falls on the provider to pick the interpretation of one-to-many is. Well, if that doesn't float your boat, there are books out there that that consultants can teach you how to use. And the problem with the books are sometimes codes aren't valid. And so what looks like a valid code, K57.3, actually isn't a valid code. You have to go all the way down to the last digit. And sometimes digits have letters that aren't very obvious. So here, this isn't a valid code, this isn't a valid code, these are valid codes. So it gets a little bit complicated. And there's a lot of other rules like it excludes and code first and additional codes, which we'll get to in a little bit. Then there are people who think that they can get every single code on one piece of paper, like the super bill of ICD-10, and really that doesn't work. And here you can see you'll need a magnifying glass to do that. And you just don't really have time in a busy clinic to figure that out. And so there are other things, right? So certain diagnoses have a relationship in ICD-10 where if you have a code that goes with it. So for instance, if you have ulcerative esophagitis, there might be a code, a drug that caused that. Maybe it was doxycycline, maybe it was Fosamax. You need to know that and connect it. If the patient has peptic ulcer disease or duodenal ulcer, that might connect to alcohol dependency or abuse, and you need to note that. There are associations with portal hypertension and peritonitis. So if we get peritonitis, is that from strep pneumo or is that from Klebsiella? We need to figure that out if the culture came back that's positive. So these are all things that a crosswalk or a book is not going to help you with. And then there are code firsts, things that code before the code that you wanted to do. So in these instances, if you have a patient who has toxic liver disease, hepatotoxicity, from Tylenol, the Tylenol code would have to go before the toxic liver code. And these don't have any rhyme or reason. It's just the rules that are set up before us. So with that, I wanted to give you a sense of what the challenge was ahead of us, and then also what our solution is. And Dr. Servoss is going to be demonstrating that to us, and we're going to just get the reflector up and running.
All right, thank you, Michael. So as Michael said, ICD-10 is incredibly complex. And what what we've done is we've built a way to make it very easy for physicians at the point of care to not stop their workflow, but to have all the complexities of ICD-10 completely embedded in the system. So what I'm going to do is I'm just going to go through a classic scenario of a patient with Crohn's disease that you're going to see in the office. So here I am with my chief complaint, a patient that you're seeing for the first time. You know that they have Crohn's. And what you see here, I'm going to walk through the history of present illness. All of the content that you are seeing in front of you is content that Elliot and I have built in. So what you'll see is that it is very specific to gastroenterologists, from the questions to the content. And what is great about Emma is that you don't have to go in the order in which you're seeing this information. You can skip around depending on how your history is going. So I've finished my history of present illness, and what you see before you is a wonderful history of present illness in prose form. These are full and complete sentences. And we've done that just with touching and clicking from screen to screen. Now I'm going to move into the physical examination. All of our physical examinations are documented by exception. So if you happen to have a normal exam, you can complete it with 2 clicks as I just did. The impressions on the left-hand side, you see that Crohn's disease is a common disorder that I see in the office, and so that automatically will populate, and I will select some counseling for Crohn's disease. And I'll show you here that we have already embedded a lot of medical content with respect to counseling. Expectations regarding Crohn's disease, nutrition, you can choose certain diets, medication counselings depending on what stage of therapy, if you're on a ramp-up stage moving into biologics or otherwise, and then also diagnostic options. So all of these have already been built in. What I'll show you here is that we have our ICD-10 expert. As Michael had shown you on one of the screens, there are various codes, almost 35 codes for inflammatory bowel disease in and of itself. And you need to know the location as well as complications. If this patient, for example, has Crohn's ileitis without complications, or let's just say it's fistulizing disease, you're already your ICD-10 expert and you've documented that. In addition, if you notice that this patient also has an associated diagnosis important for billing purposes, such as pyoderma gangrenosum, it's easy to access that diagnosis as well. And what you'll see if I go directly to our encounter form, which lists our ICD-10 and associated diagnoses, You can see that just by using the ICD-10 expert, we've noted the location, any complications, and the appropriate ICD-10 code, K50.013, and the associated code of pyoderma gangrenosum. So again, automated, easy workflow, and that took me less than a minute to do to document the patient visit instead of adding on 2 to 5 minutes for those crazy-looking super bills. So that's one example of ICD-10, a very complicated code with Crohn's disease. I'm now going to show you a couple of others that he mentioned. The first codes. So he had mentioned hepatotoxicity. As a hepatologist, I do see abnormal liver function tests quite frequently. So I'm going to go ahead and look for that chief complaint, abnormal liver tests. And if we have a duration over a couple of weeks, you can see that, again, this type of content, mild, moderate, severe, these gradations are very specific to the types of patients I see, and it makes the workflow very easy. So again, we're finished with our history of present illness, a very straightforward presentation of abnormal liver function tests. Through my history, I believe that it's probably related to Tylenol, low levels of chronic acetaminophen ingestion leading to hepatotoxicity. I click my impression. I'll move forward with some counselings, and I will go to my associated diagnoses once again, and I will click poisoning by Tylenol accidental. When I click save, and again, I go to my note output, just looking at the billing component, this was a first code. So in other words, we have to put in our billing the first code of toxicity by the non-opioid analgesic, acetaminophen, followed by the code for toxic liver disease, which is K71.0. So that's an example of the first code. The final example that I will show you is he had mentioned peptic ulcer disease. So let's do a case of that. All right, to get our ICD-10 codes, all I'm doing is changing the date. We're just going to go to November of this year, so we're sure to pull up the right code. If I have a patient, let's say, who's presenting with abdominal pain, I'll go through the history a little bit faster just so that we can get to our diagnosis portion. Again, I'm going to do a physical examination. And I will choose my peptic ulcer disease code. And alcohol dependence will pop up. And you will see on our billing form, peptic ulcer disease, and then the alcohol dependence. So again, that's an associated code that's important for billing purposes. And as you see through the workflow, it's well automated within EMA-GI.
Thank you so much, Julie. That was great. So as you can see, EMA automates ICD-10, saving time, money, and effort. If we can narrow down the thousands of codes to the ones that make clinical sense and relate them to only the diagnoses that they make sense for, and then order them front, back, sideways, right, left, then we're cutting down a lot of time for you. You're not there searching for the 7-digit code. You don't need to worry about the associations and flip back and forth on that 1,600-page manual. We have it there baked into the product. Let's talk a little bit about meaningful use and switch gears. Meaningful use, if you ask, the government has been a huge success. About 93% of all physicians are live on some EHR, but there's definitely a gap there. Only 3/4 of physicians are demonstrating meaningful use, and if you even look further, like specialists, like gastroenterologists, you'll notice that they're among the lowest successful attesters. So here, basically, only about 3/4 are live on an EHR, and less than 50% are successfully attesting. So there's definitely a gap there that specialty-specific solutions can fill that are not being met. And if we look at private practices, there's a lot of consolidation in gastroenterology. There's a lot of larger practices. You can see in the private practice large market, only about less than 75% are live on an EHR, and only about 30% are successfully attesting. So there's a huge need for something that makes meaningful use in PQRS and ICD-10 simple. And finally, this is from the ONC from February. You can see here that there's about 530,000 eligible professionals, and about 42%, or about 250,000 of them, were eligible for stage 2, but only 24,000 of them attested. And even of those that attested by November, only about 60% of them actually did stage 2, and the other ones did stage 1 for a third time. So there's definitely a gap there from a usability standpoint, and CMS is aware. Here you can see that the adoption rates for basic EHRs, which are certified, are much lower than the higher percentages we're looking at for people live on some form of electronic medical record. And finally, the bottom line is only about half of the eligible providers are actually getting money, in some cases much less, which tells us that this meaningful use isn't so easy. But that isn't preventing the stick, right, from happening. So in 2015, if we're not attesting, then in 2017 we're given a 3% penalty, and that could go up to as high as 5% penalties in 2019. So there is an MU backlash. Surveys have shown that 70% of respondents say EHR decreases their face-to-face time, and absolutely meaningful use is part of that. And about 55% of physicians say they want to test for stage 2 in 2015. That led CMS to announce that they are considering reducing the complexity, lessening the reporting burdens on providers, and they are going to shorten the reporting period from 1 year to 3 months, which gives an opportunity for providers to switch from what they're currently on to something that's going to help them. We expect the confirmation of this to be this spring, and this is directly from the CMS website. So let's talk about the pain of, or the poison of meaningful use stage 2. Obviously, it's more time consuming than stage 1. There's a real penalty if you're collecting $500,000 of Medicare reimbursement. That's a $15,000 penalty in 2017. That's a pain you're not seeing yet. It's kind of like carbon monoxide. It's colorless and tasteless, but it can still kill you. So you want to be aware that this is actually going to happen. And then if you don't lose money in the penalty, you could lose money in front desks or staff time or provider time. And some people think there's a conspiracy between EHR companies and CMS, and I want to dispel that myth. Some people feel that EHRs are charging the exact amount to offset the penalties that CMS incurs. I can assure you that our customers are only physicians, that we are not in cahoots with this. And to prove the point, EMA is much less than, the annual cost of EMA is less than the meaningful use penalty alone. So if you went with any of these barriers, you would find out that you can make an ROI on any one of them individually. Here you can see the top 30 vendors in the United States for electronic medical records. We are up there. Modernizing Medicine is within that top 30. We're one of the only specialty-specific options. There's another 730 vendors that aren't making this list, but you can see that we're making our way up towards Epic, really providing the surgical subspecialties and medical subspecialty solutions. We have services on top of our offerings. For those of you that don't really want to have to deal with this, it's kind of like doing your taxes. You have an accountant that helps you, and that kind of reduces your stress. We have meaningful use coaches that we can answer unlimited questions for you via email that spend an hour or two per month with you to make sure that we're correcting habits so that there isn't a surprise when you attest. And this has an over 95% success rate, which is much higher than the 50% that you're seeing for specialists, or the 30% that you're seeing for large private practice. So EMA is less than the MU penalty. If you don't attest for meaningful use, you lose $15,000 in 2017, and the annual subscription of EMA is $9,000. That saves you $6,000 on just MU. Moving on to PQRS. So Jane is part of a 10-doctor single specialty gastroenterology group. She's on a legacy EHR system that slows her down. She's using a third-party PQRS system where she has to hire additional staff to answer the yes/no questions. It was too time-consuming this year. She's thinking of not doing it. They know that PQRS is switching from pay for reporting to pay for performance. In 2015, they don't have time to report on 9 measures across 3 domains. Jane's practice collects $4 million in Medicare each year. What does her practice stand to lose? So here you can see that there's time, money, and staff. So from the time standpoint, there's 2015, there's 9 measures you have to attest, not 3. It's pay for performance, not pay for reporting. That's about 2 to 3 weeks of data entry per provider. That's a lot of time. But then there's money. So in this year, PQRS is linking to the value-based modifier. So there's penalties incurred in 2017 for non-PQRS participation in 2015, ranging from 4 to 6%. That varies by group size. So if you're in a 1 to 9 doc group, you'll be penalized 4%. If you're in a 10 doc group or more, you'll be penalized 6%. Based on $500,000 of Medicare revenues, that's between $24,000 and $12,000 per extender. And then obviously there's increased data entry, which you're relying on your office manager, your provider, your MA to do. So let's talk about PQRS. In 2015, it's paid for performance. You need to report on 9 measures in 3 clinical domains, greater than 50% of your Medicare Part B patients, and 1 measure has to be a cross-cutting measure. There is the penalty for non-PQRS participation has increased from 2% to 4 to 6%, linking to the value-based modifier, which we'll talk about. So cross-cutting measure examples, the 2 that we like to recommend are current medications in the medication record and preventative care and screening tobacco cessation. These ones are very easy to do and are, even though they're not potentially GI specific, don't require a lot of extra work. What are other people doing? Other solutions have questions like these, which are yes/no questions for any given measure. If you do the math on them, that's 9 measures, 10 to 20 yes/no questions per measure, anywhere from 1 to 5,000 patients. It adds up to 125,000 yes/no questions per provider per year. That would take several weeks to do, which is why we don't do it that way. So without further ado, I wanted to give it back to Julie, and she can show you how we handle PQRS.
Great, thank you, Michael. So for the PQRS, I thought I would do a common type of patient that I see, which is hepatitis C. And I'll show you how EMA automates the collection of PQRS data, including cross-cutting measures. So for hepatitis C, we're just going into the chief complaint, and I'm going to pretend like this is an initial evaluation for a patient who's had hepatitis C for 6 years. And again, as I go through the history of present illness, you'll see that the medical content is in line with types of questions that we'll ask, even to liver biopsies and grades. If I go skip to testing, I wanted to note that Elliot and I have built in some reminders in the history of present illness when there are PQRS measures that are common for a certain diagnosis, such as hepatitis C. So you'll see here that we prompt users with the parentheses required for PQRS. The first one, hepatitis C antibody test performed at this initial visit, which we'll do, RNA testing, and then documentation of hepatitis A vaccination status. So if I've confirmed through history that it was previously administered, I'll be all done with this PQRS component. And in the history of present illness, you can see again what I had noted before, complete prose and narrative of the history of present illness. And I'll go into my examination once again. Most of our exams are normal, and when I document by exception, it's done very quickly. Hepatitis C, chronic infection is my impression, and you'll see that my popular plans, which include counseling for hepatitis C and ordering tests, show up on the left-hand side. First, on the right, I'm going to document that in this patient, they actually are asymptomatic, which of course is typical. And I'll go into my counselings. Here again is where we've built in a lot of counselings with respect to expectations, nutrition, any medication counselings. And we'll be done with that depending on what I choose. We've also built in laboratory studies in a templated form. So initial evaluation for hepatitis C, you can click that. If I expand that, you will see that it is the prototypical initial evaluation test for anyone presenting with chronic hepatitis C. And I can be done with that also very quickly. At the same time, I have realized in our PQRS measures that we also have to think about other information we want to elicit during the visit. For example, CAGE questionnaire in any patient with hepatitis C, of course, we're going to ask about any alcohol consumption. And I can go ahead, understanding that this is perhaps a PQRS measure I want to fulfill. And again, I have documented that in my history of present illness. I'll go back into my examination room, and I've realized that, again, for this patient could be eligible for influenza vaccination at the time of this visit. And so I can also go ahead and immunize at the point of care. And I'll be done with that procedure. I've administered it, the nurse has administered it in the deltoid, and we are all set. If I click on that More box, you'll see about the third row down on the far right is a PQRS button. And what I can demonstrate is that for our measures, we'll look at influenza vaccination. It's already been documented in our system. Documentation of the medication which was one of those cross-cutting measures, has also been fulfilled. Hepatitis A vaccination, if you remember in the history I listed that they've been previously vaccinated. That's also a favorable outcome for that measure. And then the tobacco screening and use, also a cross-cutting measure, is a favorable result. So again, in that workflow, that is a very common visit that I do. That was less than 2.5 minutes, and we're all set with our PQRS measures. In addition, the ICD-10 codes, we see those there, and this is our complete office visit.
So what's really cool about this is it's using structured data underneath the pros to figure out what you pass and what you don't for PQRS without your having to enter it in additionally. So Julie, she just put in the medications there, and she got credit for that measure. She did a case assessment as part of her history and got credit for that measure. She put into her hepatitis C history that they had a certain vaccination and got credit there. So you're getting credit all over the place by just doing your normal workflow, and that's the way to pass PQRS as we switch from pay for reporting to pay for performance. So again, try and avoid these poisons. You want to save time, you want to save money, you want to save staff. You do that through automation, through structured data, rendering multiple measures for PQRS all at once is favorable without having to double enter it in. Let's talk a little bit about the value-based payment modifier. So as part of their better care, lower spending initiatives, Medicare has linked a lot of the fee-for-service to quality. And I want to calm everybody's fears. Most of the alternative payment models like ACOs and episodes of care bundling are around acute hospitalizations, are around end-of-life care, around dialysis. They're not around colonoscopies and office-based visits. So this blue doesn't affect us. The light blue does. And that's really where they're linking the value-based modifier, PQRS, to fee-for-service. And how they do it is through the VBM. So what's value-based payment modifier? Think of value-based payment modifier as Robin Hood. And Robin Hood's going to look at people's practices, and he's going to decide what the quality is based on PQRS performance and what the costs are, and it's going to take from people who have below performance and give it to people who have high performance. This is budget neutral. We're just taking money from some practices, and CMS is giving it to others. So people who perform better on PQRS could get a rate increase. They could get a pay raise. People who are at average performance have their reimbursement unchanged. People who are below the national mean could actually get a pay rate decrease. And what you do this year determines what happens in 2017. So solo practices and physicians up to 9, if you don't participate in PQRS, you automatically lose the 4%. But if you do participate in PQRS and you do well, you can get a pay raise. You can get an upward adjustment, or at least a neutral adjustment. If you participate in PQRS, you will not get a downward adjustment if you're a small practice. If you're a large practice, you can be subjected to upward, neutral, or downward payment adjustment depending on your quality tiering, which we'll get to right now. So here we can see different rates of quality: low quality, average quality, and high quality. This is determined by performance rates in PQRS as well as a couple of other things. People with low quality with high cost get penalized 4% if they're in a large group. People with average cost and low quality get penalized 2%. People with average quality and high cost get penalized 2%. Medicare will then take that reimbursement and give it to providers in large groups who have a higher quality and lower cost, or an average quality with a low cost, or an average cost and a high quality. And for those that are in smaller groups, you get none of the downside and all of the upside for participating in PQRS. Let's talk a little bit about medical necessity. Julie, do you want to take us through that?
Yeah, there are two important key points for gastroenterologists. The first one on the review of systems, those do have to be related to the chief complaint. So although we're all trained in internal medicine, we do have to gear our targeted 5 to 7 questions on our review systems to the chief complaint, for example, abdominal pain. The other one that we've worked on automating within EMA Gastroenterology is ordering screening versus diagnostic endoscopies. This was really important. This was news to me as I was beginning to learn more about medical decision-making within E&M codes. Right now, your level of risk is determined by whether you're ordering a screening or a diagnostic colonoscopy. What that translates into is a low risk versus a high risk diagnostic colonoscopy. So both of those are options, and this helps to improve your medical decision making and therefore your coding. So at the end of the day, it's more money in your pocket, obviously, if you're doing higher risk procedures.
Great. Let's talk a little bit about telemedicine. So mobile health is a huge industry. We estimate that it'll be a $27 billion industry in 2017. And there are telemedicine companies out there that are offering remote services for your patients, with chronic conditions. And so we are building a telemedicine application that we're opening up to our existing user base so that they can participate in the revenue. There is a final rule, October 2014, where they're creating CPT codes to covering the remote patient monitoring of chronic conditions. These chronic conditions need to be life-threatening or disfiguring or affecting their function. There are a lot of chronic conditions in gastroenterology that affect how you treat your patients. And so this is a revenue opportunity. So we're building a synchronous mobile application, both on the iOS device and Android device. There's an initial launch that will be Q3, Q4 of this year. We're starting in dermatology, but we're going to open it up to our other specialties, including gastroenterology. Patients can log in, submit a case, put in a history, fill out information, send a picture if need be, and physicians can then review the lab results, review the case, make an intervention, whether it's ordering more labs or prescribing something, and then you can get paid for that. And we're looking at models of reimbursement, whether it's through insurance or through the patient as well, to give you a way of getting added revenue. So with that, I just want to kind of summarize how we're different and how what makes Modernizing Medicine different really position us to help you with all of these compliance regulations. So the first thing is we're cloud. We're true cloud. We're single instance. There's a single copy of our software that we're updating that we deliver to all of our gastroenterologists. That means we're scalable, we're searchable. As trends change, we can change the product, improve it. Everybody gets the same copy. We're mobile. Mobile is a $27 billion industry. Telemedicine is going to be big, and we want our clients to participate in that revenue. And having a company that has a certified mobile product for meaningful use, that has native Android and iPhone capability is very important for our user base. And we have structured data. And that structured data gives us the ability to automate PQRS documentation, to automate ICD-10 documentation, to make it less onerous on meaningful use stage 2. And that obviously translates to 7 to 9% of your bottom line for Medicare. At the nexus of mobile and cloud, there's telemedicine applications, which we've talked about. At the nexus of big data and mobile, there's the ability to adapt so that the provider knows how to document without having to tell it, and that saves the doctor time, avoiding this trap of paying a lot of money for an EHR that slows them down. And finally, the nexus between cloud and big data is the wisdom of the masses and the ability to collect structured data to make it fast. And we're at the center. So don't get fooled by false choices. There's a lot of potential ways to lose money, whether it's revenue, time, or staff. Don't go for a solution where you gain in 2 and lose in 1, because that's the zero-sum game. And instead of just commenting on the problems, we're offering real solutions. We're automating a lot of the ICD-10 documentation. We're simplifying meaningful use stage 2 and offering services on top of it. We're automating much of the PQRS measures so that you can have a higher performance so that you're not taking this big cut in reimbursement with the value-based modifier. And we're offering a telemedicine offering that will be revenue generating when the rest of the climate is not. So with that, we wanted to open up for any questions that you may have. Thank you so much for your attention, and we appreciate it. So one question that I think a lot of people have is, do you think that ICD-10 will be delayed again? And so for those of us that were here around this time last year, CMS pushed forward with ICD-10 deadline in 2014. It was delayed because hospital administrators weren't ready, because private practice wasn't ready. We have every indication from CMS that they do not intend to delay ICD-10, that it will be a driving force this year. The EHR associations, the AMA, everybody believes that it will actually happen this year. Another question we get asked is, does EMA have a patient portal? EMA does have a patient portal. It is part of the offering, so it's not any extra add-on. It's nicely integrated into the system. Patients can direct mail for meaningful use. Patients can review some of the results through the portal. So it's a very nice feature. One question that we get asked is, if you are starting an EHR in 2015, do you still have to meet MU requirements? So the answer is yes. The incentives have gone away for 2015, but the penalties remain. So for those that are just starting or looking, coming from paper to EHR, in 2015, you do need to attest to avoid a penalty of 3% in 2017, even if you are new to EHR. One question we get asked is, can you meet measures for PQRS that aren't necessarily related to your scope of practice if you're in a different specialty, or do you have to meet the measures within your own specialty? And the answer is that any measure that you have patients on, you can report, as long as they are Medicare patients and they meet the criteria. So if you saw a patient with otitis externa, you can report on that measure. If you saw a patient with a URI, you can report on that measure as well. And Howard has a question. I'm going to unmute Howard.
What is...
Hello, Howard. You're on.
Okay. What's the cost of the EMA? And how about the cost of transitioning from one EHR to EMA?
Great question. I'm going to just mute you only because there's a little feedback loop there. So EMA is a monthly fee. It's not a client-server application. So client-server, you're typically paying the cost of a Lexus or a Porsche, and then you're sticking it in your closet because it doesn't work. Our system is a monthly subscription. If you don't like it, then you can just stop paying us monthly. And the current price of our product is I believe it's around $650 a month. I will confirm that. And that includes ICD-10 and some of the other functionality as well. There are, the second part of your question was asking around questions for converting. And we get a lot of these. Like certain people are stuck on old technology and they want to know, hey, can you convert? And the answer is we do have converting solutions for you. Converting isn't perfectly clean, but I think you just deciding on what you want over like certain PDF notes and things like that, we can do through a third party. So we can kind of connect with you offline and kind of delve into what solution you currently have. Justin asks, can you explain more about the direct mail feature? How is reimbursement affected by this? Right. And so Justin asks, so yes, that's part of direct mail is a meaningful use stage 2 requirement where patients have to direct mail your practice. They don't have to necessarily direct mail you, the provider. You can set up a group email. And basically 5% of your patients need to contact you for the reporting period for meaningful use. I particularly don't really love that feature, but there's ways of just attesting for it. Reimbursement is different, so there are codes for telemedicine and chronic care management. So around that is basically getting paid by CMS for Medicare patients with 2 or more chronic conditions, where you hire a care manager who reviews and spends time with patients remotely for about 20 minutes a month, and then they get paid a certain code for care management and an additional code for telemedicine, which adds up to being about $100 a month per patient. This is new. It's part of the final rule that hasn't been confirmed. We expect it to be confirmed later in the year, and there'll be guidelines from societies on what a chronic condition means and what you need to meet that criteria. But we are building the mobile application that can handle it in advance of understanding how these rules shake out. A great question. We are also offering for a select few, we're about to wind down the program, but we do have a couple open beta slots for gastroenterology for those of you that are interested in betaing, and that has a reduced price of $200 a month. So that is going away, but for those of you that are potentially interested in helping us, that would be great. We'd love your feedback. Just so you know, Modernizing Medicine has about 5,200 providers nationally using our product. You're not betaing the platform. It is a certified 2014 platform that has e-prescribing and can connect to practice management systems and has patient portal and has all of these mature features. You're betaing the GI content. And obviously that was made by Dr. Servoss and Dr. Ellis, and he's already using that in his practice.